All this is Dr. Mobeen Sayed. Welcome to one more show. So the discussion today is a number of news, and then we would discuss the myocarditis, which is a rare occurrence, mostly with the messenger RNA type vaccines, mostly in men, mostly in young men. And you would see in the data that I would present that at least the data that we have, all folks who developed myocarditis, some ended up in hospital and some stayed home and were recovered. So everyone recovered. There is no death related to that. However, this question has been very common that, hey, how does the myocarditis occur? Which vaccine? Is it the aspiration, not aspiration, and so on? So I wanted to go over American Heart Association's article about this and what they have found so far. So this is not a discussion to make us like or dislike vaccines. Instead, this is a discussion of just looking at the data. So let's start. Oh, I'm so sorry. This strobing occurs every once in a while, and I have no idea why. So I'm going to change this. All right. So this is drbeen.com. This is trial site news. Double standards. Dr. Mobeen Sayed reviews the hurdles faced by ivermectin and molnupiravir in the COVID pandemic. Then this is an interesting news, and thank you for a cool bean who shared it. World's leading ICU doctor files lawsuit against hospital system after being barred from administering safe and effective COVID-19 treatment. So this is Dr. Paul Merrick, who has so Paul Merrick, MD, one of the most highly published critical care physicians in the world and the director of the ICU at Sentara Norfolk General Hospital, was recently told by Sentara Healthcare that he could no longer administer a range of highly effective COVID 19 treatments to critically ill patients. So you can read the rest. But this is an interesting news. Here is another interesting news that appeals court has temporarily halted Biden's vaccine mandate for large businesses. And if so, you all know that I have always um, kept myself from saying that you should take the vaccine or you should not take the vaccine. And I have always presented myself. And I have always said, I am vaccinated, Moderna. My older son is vaccinated, Pfizer. My younger son, and he's still an adult, 23, 24 years. So my younger son, and I told the range, I don't want to tell his exact age. My younger son, Moderna, and my wife, Johnson and Johnson. And you ask us 10 times, we will get that vaccine. So because there is a benefit of the vaccine. So that is about the vaccination. And then let's start our discussion. There are two studies or articles in front of us. One is this one. This is myocarditis with COVID-19 mRNA vaccine. This is in American Heart Association. If I go here, if you can see here, AHA journals. So this is American Heart Association journals. This is their article, very well written. What the authors have done is that they have gone over the epidemiology, the incidence in the US, in the world, in Israel, what kind of vaccine, what gender, what age range, what comorbidities, what is the percentage or the incidence of the myocarditis, how are the patients becoming recovered from it, what is the possible pathologies, and what are the possible managements. So I feel the whole structure is packaged into this one article. So get ready to go through this with me. And then there is also another article. This is not in AHA, this is instead in JAMA, and that is myocarditis occurring after immunization with messenger RNA based COVID 19 vaccines. So, again, the point here is not this to say vaccine causes this. Instead, the point is so we have all had these discussions. The point here is to figure out what is the incidence, what are the symptoms, what kind of tests are done, and how the management is done. So, rather in depth, look into it so that if somebody has this fear, they can understand that how this progresses, what are the chances, and what is the severe outcome. There is actually no death because of this. So that is important. They both, I think, articles have done a comparison to COVID as well. So I am not going to go into the comparison with COVID too. You can just generally know that COVID is much more dangerous and would cause more severe myocarditis, higher incidence, more long-term damage as well. So let's look at the data and the article itself. So I'm going to try to see if I can make it a little bigger. So here, first of all, according to the US Center of Disease Control and Prevention, myocarditis, pericarditis are 12.6 cases per million doses of second dose of mRNA vaccines among individuals 12 to 39 years of age. So this is the first data point to keep in mind. 12.6 per million, second dose. Then, in reported cases, patients with myocarditis invariably presented with, so how do they present? Chest pain, usually 2 to 3 days after the second dose. So this is a very common question, that when should I be worried or when should I be aware? So 2 to 3 days after the second dose. Mostly, so 60-70% of the cases are after the second dose. And had elevated cardiac troponin levels. Cardiac troponins are the enzymes. So when you break a cell, just like if you open a fruit, it's a weird example, but go with me for a second. If you open a fruit, there is something inside, and that whatever is inside would come out. Similarly, if you break a cardiac cell or any body cell, whatever is inside the cell, that can come out. And if there are something specific for that cell, these can be measured. And for example, cardiac troponins are the proteins or enzymes that are present in the heart muscle cells only. So if you find them in blood and you find them above a normal level, then you know that there is some cardiac tissue damage that is happening. EKG was abnormal with ST elevation. ST is the ST segment. So if I can very quickly draw an EKG here to point out what they're talking about. So in an EKG, so let's say this is the P wave and this is QRS complex, and then here is the the T wave has become too far off, and here is the T wave. So P wave, QRS complex, and the T wave. So ST segment elevation is this part becomes elevated. So this happens in cardiac tissue damage. This could be depressed as well. So here we are talking about ST cell segment elevation. So that is found on the EKG. So again, important things for the doctors to keep in mind. Cardiac MRI was suggestive of myocarditis. So when the MRI or magnetic resonance imaging was done, the imaging showed edema or inflammation of the cardiac tissue. And so that can be seen with MRI, or that color can be seen, and that was indicative of the myocarditis. There was no evidence of acute COVID-19 or other viral infections. So it was not. So we're talking about post-vaccine. So they said that we ruled out was it COVID related or vaccine? So there was no evidence of viruses. Viruses can cause myocarditis. In one case, a cardiomyopathy gene panel was negative, but autoantibody levels against certain self-antigen and frequency of natural killer cells were increased. So these are another couple of things I would like us to keep in mind. Although we'll come across this a little later in the talk as well, when we will talk about the pathologies that cause this issue. So just keep in mind for the time being that natural killer cell levels are more, and number two, autoantibodies are increased. And I'll explain what does that mean later on. Although the mechanism of development of myocarditis are not clear, molecular mimicry between the spike protein of severe acute respiratory syndrome, coronavirus, and self-antigen trigger or pre-existing regulatory immune dysregulation, etc. So remember, I have been talking about molecular mimicry. That may be one mechanism. So here, a summary of all the pathologies, potential pathologies, is we actually do not know what exactly is the problem. We do not know what causes the harm. We know that this happens. We also know that most of the time it just recovers by itself. Sometimes patient goes to hospital and still it recovers within 3 4 days and they come back. But exactly what caused it is not known. And so they're going to go over all possible mechanisms that could be there. One of the mechanisms I've been talking about is molecular mimicry. They're going to talk about that as well. And so for those who believe in it is aspiration or not aspiration related or vaccine injected in blood vascular system, they would be a little disappointed that these authors did not discuss that mechanism. Now, there is a male predominance, younger age, male, after second dose. And so the reason, why is it men? Why is it boys or young men? And that may be because of the hormonal differences from women. Men have more testosterone. Testosterone predisposes them more towards inflammatory outcomes compared to women, premenopausal women, or women who are not in menopause. I shouldn't say premenopausal, that's a different term. Women who are in menstruation age, they have estrogen that is more, and estrogen is usually anti-inflammatory or reduces the inflammation, so they may have some benefit. So look, almost all patients had resolution of symptoms and signs and improvement in diagnostic markers and imaging with or without treatment. And in this article, what I really love is that at the end of the day, they have talked about the treatment as well. And this is what I have always been talking about, that when you are talking about vaccine related injury, the point of doing that should not be here is a vaccine and here is what it would do. The point for medical groups, I mean, there are folks who have other point of views and other discourse. For example, there are politicians and there are others. For medical groups, it is important to understand how to manage. And for how to manage, we should know what is going on, what are the tests to be done, and then how to manage. So this article has that all here. Despite rare cases of myocarditis, the benefit risk assessment for COVID 19 vaccination shows a favorable balance for all ages and sex groups. Therefore, COVID 19 vaccine is recommended for everyone 12 years of age. I think this is an important statement that everybody makes, that, hey, while we look at those things, please don't think that this is a, um, a ding on the vaccines. Okay, now epidemiology. This is interesting. So I have my sons, their age is more 24 28. Now I've told you the exact ages. um, but there are people with younger children, and so this question is very common. Even I had this question in my mind when my children were going out, that, hey, what is their risk? So in the general population, myocarditis is diagnosed in approximately 10 to 20 individuals per 100,000 per year. So keep this in your mind. In 1 year, for 100,000 people, 10 to 20 will have myocarditis, and occurs more commonly and at younger ages in males compared with female. That is the standard general behavior of myocarditis. And the thought is, as I said before, may be related to hormones. Now, then they talk about where's and the method around that. So I'm going to skip that part. I am more interested in talking about what is the epidemiology, what is the pathology, what is the management. So here, according to the Advisory Committee on Immunization Practices, after 300 million COVID-19 vaccine doses administered through June 11, 2021, there were 1,226 reports of probable myocarditis pericarditis cases in VAERS, 67% of which followed the second dose. This is also important. 79% were in males, 79% were in males, with the majority in individuals lesser than 30 years of age. Males lesser than 30 years of age after the second dose with a messenger RNA vaccine. Now, this is important as parent, as the patient, or not patient, as a person who is receiving the vaccine, time to onset of symptoms was a median of 3 days, with the highest rate at day 2 after vaccination and among patients 16 to 18 years of age. So this was the group highest rate, 16 to 18 years of age, day 3, and a second dose. Myocarditis, pericarditis among patients lesser than 29 years of age that were reviewed and characterized with the CDC, 86% had reported of a chest pain on presentation. So if you are a healthcare worker, you're a doctor, you're a nurse, you're a nurse practitioner, other healthcare workers, patient would say chest pain. 61%, so that is 86%. 61% had reports of ST or T wave changes. So if I go back to this thing, so change in the ST or change in the T wave, that is this T wave. So let's say changes. I'm exaggerating just to show. Then 64% had reported elevated cardiac enzymes. So again, if the cardiac tissue is broken, some part of some cells are injured, then they would release the enzymes. 17% had reports of abnormal cardiac imaging. So that is MRI. And when that is done, there is edema, which is a sign of inflammation. And that is what myocarditis is. Wherever there is itis, that means there is inflammation over there. And wherever there is inflammation, there's going to be fluids over there. And MRI can pick up those fluids. Not the fluid itself, but it can pick up on the image, the presence of the fluid. In 323 of the reports that met the CDC definition of confirmed myocarditis, 96% were hospitalized, but most were discharged with a resolution of symptoms. The observed myocarditis pericarditis report were higher than expected case rates of males compared with females. So we are saying it like 10th time now. Okay, so this is an important chart as well. So look at this one. This is actually very interesting. Age group, see here, this is 12 to 17. I'm just gonna, come on, making it a little bigger. I cannot click it. Every time I click this, it is gonna either become small or then expand again. So 12 to 17 years, females, 2.18 million doses administered. Expected myocarditis was 0 to 2 in this age, they were vaccinated or not. And they had observed 19. So that was the increase. In boys or young men, 2.039 million doses were administered. Expected cases were, if these were just the background cases, 0 to 4, and instead they observed 128. So there was an increased incidence. But you would see down below that the incidence per million is, of course, not. This is the total doses given to this age group. For example, here 2 million, here 2 million. 18 to 24, you can see now 23, 219. And as the age advances, this chance reduces. So if I go down here to 65 plus, 21.7 million doses given in females, 4 to 42 were expected, 10 occurred. So almost normal, meaning background rates. And in men, 18 million doses were given. Expected were 3 to 35, and the occurrence was 11. So as if it is background. So if you see younger the age, a higher propensity for this pathology. So then this is the CDC's chart for what are the signs and symptoms. For example, probable case of myocarditis, presence of more than one new or worsening following cases. So you can read this. There is a possibility of probable case, there is a confirmed case, and there is acute pericarditis probable case here. So usually what are these things? Chest pain, pressure, discomfort, dyspnea, shortness of breath, palpitations, syncope, fainting, and histopathological confirmation of myocarditis, for example, either the tissue biopsy or the markers, elevated troponin, and no other identifiable cause and symptoms of other diseases that may cause this, or other diseases themselves. Okay. Now, 12 to 39 years of age, in the 7-day risk interval after vaccination with mRNA COVID-19 vaccine compared with unvaccinated individual, their risk was more. So this is the most at-risk group. The estimated myocarditis, pericarditis chart confirmed rate, meaning where you have confirmed it, rate, and you put that in the chart that this is myocarditis or pericarditis, was 12.6 cases per million. 12.6 cases per million doses with second dose messenger RNA vaccine among individuals 12 to 39 years of age. You would see that there's a lot of data being repeated. All chart confirmed cases with follow-up had resolution of symptoms. This is important because at the end of the day, if we are worried that he'll get the myocarditis, the question is what would happen next? So all chart confirmed cases with follow-up had resolution of symptoms, and among those who had follow-up EKG and echocardiograph and lab testing, most had returned to normal or baseline on the follow-up. So let's say you ask them second day, third day, fourth day. By that time, they had become normal. On this basis, the Food and Drug Administration will add a warning to the product label of both mRNA vaccines. Now, this is myocarditis, pericarditis rates based on international classification. Again, what is interesting in here, if I expand this table, is the following. Any mRNA vaccine, dose 2, female cases for rate 4.7 per million with this confidence interval, 1.3 to 12. That is with 95% confidences. Males, 22 per million with the confidence of 20 to 48. That is what is, if you wanted to just take away what is the incidence rate, this is the incidence rate. I think for healthcare workers and for us in general as well, what is the pathology and how to manage is also going to be important as we discuss further. But at this time, let's just keep this in our mind. For 2 doses, women, females, 4.7 per million, males 22 per million. 1 dose, 1.9 per million, males 4 per million. So once again, how did they present? Chest pain 2 to 3 days after the second dose of Moderna vaccine. So do you see how much of the repetition is in there? These were predominantly young males requiring hospitalization for myocarditis and without a history of COVID-19 or comorbidities. So they're talking about these were healthy individuals. They did not have COVID. So we couldn't say that this myocarditis is because of COVID. This was after the vaccine. Now, was it exactly the vaccine? That still is a association, but that association is now recognized. I remember when I started talking about it, I was really pushed back in a very heated and aggressive manners by many, but it is recognized now. All tested negative for current COVID-19 by polymerase. So anyways, here I'm going to continue. Almost all patients had resolution of symptoms and signs and improvement in diagnostic markers and imaging with or without treatment. And they have this table for how the treatment went. We have treatment laid out next as well. Israel reported 148 myocarditis cases among 10.4 million vaccinated individuals occurring within 30 days of mRNA vaccine. A majority after a second dose, mostly in males 16 to 30 years of age. And if you see here, this JAMA study, they also, almost every paragraph is a different study or different observation of cases, and they have also discussed those as well. I would not go into this study, this is not a study, this is a collection of various observational cases and studies, but they also have in the US, various observations. Okay, most cases required hospitalization. So we're talking Israel, up to 4 days, but were considered mild. The report suggested a probable link between the second dose mRNA vaccine and myocarditis among men 16 to 30 years of age, with a stronger link for age 16 to 19 and decreasing association with older age. The prevalence of myocarditis was 1 for 20,000 for 16 to 30 year group compared to 1 to 100,000 in general population. Okay, so I'm gonna now, this is then they discuss the COVID related myocarditis. So comparison of vaccine caused or related, associated, and COVID related. So this is that discussion, and you can look into this. I am still more interested in possible mechanisms and management. So we are there, possible mechanisms, and then we'll do the management, and then we're done. So they have looked at, interestingly, a lot of mechanisms, and I am actually fascinated by them. You know that I get fascinated by the mechanisms. So first of all, RNA molecule can be immunogenic. So the first mechanism, what they're saying is that we know in the messenger RNA's case, let's say here is a cell, and here we have a lipid nanoparticle, right? So we know that inside the lipid nanoparticle, we have packaging or packaged messenger RNAs, correct? This lipid nanoparticle fuses and then enters the cell. Then these messenger RNAs are liberated inside the cell, and then they're used to make spike proteins via ribosome. We have done that discussion. They are saying, first mechanism, possible mechanism, if this messenger RNA is released out, let's say that this cell is destroyed, and when the cell is destroyed, this messenger RNA is released. Or let's say this lipid nanoparticle is destroyed and the messenger RNA is released, which normally does not happen, but figure out a way that messenger RNA is out in the open. If it is out in the open, it can, messenger RNA or RNA's pieces can actually make immune cell very, very angry. And those immune cells can then start a reaction. This is an angry immune cell. However, this seems like a cell which has lipstick or something. Anyways, this is an angry immune cell. However, usually they say that messenger RNA components or the nucleosides that are used, the genetic material that is used, it is modified in a way not to irritate the immune system too much, not to become too much of an epitope for them, not to become too much antigenic for them. So hopefully, the hope is that the modified nucleosides will kind of make immune system less angry, and that means less reaction will occur. So back here, that is what they're discussing. Selected RNA molecules can be immunogenic. They can cause. So we're not talking about spike here. We're talking about the RNA itself, and stimulate the mammalian innate immune system. Innate immune system, that is macrophages, dendritic cells, natural killer cells, and so on, neutrophils. Destroying the messenger RNA before it reaches the target cells, preventing the spike protein and neutralizing antibody production, and so on. So then, to answer this one, that is it probable or not? So what they do is they say, here is a possibility, and then here is what we checked. Although nucleoside modifications of messenger RNA have been shown to reduce their innate immunogenicity, in certain individuals with genetic predisposition, the immune response to mRNA may not be turned down and may drive the activation of aberrant innate and acquired immune. So some folks may have genetic predisposition that they may not be able to stop their response to this modified mRNA, and they just respond normally to this. And so what cells? The dendritic cells or tall-like receptor-expressing cells, for example, macrophages, exposed to RNA may still have the capacity to express cytokines and activation markers in certain individuals. So this is one possible mechanism. They do not have proofs of these mechanisms. They are looking at various reasons that myocarditis can occur, and they are saying here is something that is possible. Then I'm going to continue on. So they discuss this then, and then here, there is now one more mechanism. In one case report, so this is n equals 1. In one case report, SARS-CoV-2 spike IgM and IgG neutralizing antibody levels were not significantly different in the patients with myocarditis. So now this is the second part. The second part is it possible? And this would actually address my comment that I have been giving that there may be molecular mimicry. So mimicry would come next, but still what they're saying is, if we are thinking that once the messenger RNA is there and the spike proteins are formed and then they're crushed and then pieces of them are presented on the surface, and then the immune system cells become activated, either T helper 2 pathway or T helper 1 pathway, which we've been discussing forever. And then we have plasma cells, B cells, and we have cytotoxic T cells, correct? So we have immune response, adaptive arm. They're saying if we think that this is because there are too many antibodies produced and these antibodies are causing the damage, then in one case, so again, by one case report, SARS-CoV-2 spike IgM and IgG neutralizing antibody levels were not significantly different in the patients with myocarditis than in individuals without myocarditis post-COVID-19 mRNA vaccination. So two people both got the COVID-19 vaccine. Their both antibody levels were similar. One had myocarditis and one did not. So that probably tells that it is not related to the volume or quantity of antibodies. In the same report, the patient with myocarditis had elevated levels of interleukins. So they then discuss some more. Historically, circulating heart-reactive autoantibodies have been reported at a higher frequency in patients with myocarditis. So they say that usually those patients who develop myocarditis, they generally have autoantibodies. They generally have antibodies attacking their own heart. Thus, autoantibody generation could be one of the mechanisms whereby myocarditis may develop in susceptible individuals. But check this out. However, it should be noted that in the patients studied, autoantibody levels peaked on day 2 along with the symptoms. So on the day 2, so let's say this is vaccine here, let's say second dose. 2 days later, antibodies increased, which is fine. That is the behavior of our body. The symptoms or myocarditis also occurred at the same time. So this would then make us think that there is at least because of temporal association, because of the time association, there is a link between them. But he's going to say in the next sentence over there that myocarditis then resolved in, let's say, 3 or 4 days, but antibodies stayed up for longer time. So if it was the antibodies that were doing it, then myocarditis should have continued as long as the antibodies were there. And that was not observed. So that means it may be autoantibodies, but there are cases where autoantibodies were not the reason and still myocarditis was present. So that is what you'll see here. However, it should be noted that in the patient studied, autoantibody levels peaked on day 2 along with symptoms, but they did not recede the antibodies as expected as the clinical condition improved. Although the follow-up was rather short. So they said we did a short follow-up. Maybe we should have followed up for a longer period of time. Then they talk about two more things. They have seen the patients with myocarditis to have a higher count of natural killer cells. And again, they are unable to actually say that is it the damage. So when there is damage to any tissue, let's say this is heart tissue, let's say this is the cardiac tissue, and it is damaged. It is possible that the damage itself causes inflammation, which would then cause increased number of NK cell. Or it is possible that it is the NK cell that got increased because of the vaccine, and then those cells attack this tissue. And so they say, we are not sure. We see that natural killer cells are increased in number, but we cannot say they are increased as a result of the cardiac inflammation, or cardiac inflammation occurred because NK cell attacked it. They don't know. But they saw NK cells to be more. Same is the case. It is not clear whether the differences seen in this patient regarding relative increase in NK cells, autoantibodies as well, and a dysregulated cytokine profile reflect a causal pathological immune response or reactive adaptive response to myocardial inflammation. So they say three things they observed in a patient: more NK cells, then more autoantibodies, and a dysregulated immune system cytokine profile that they discussed here in this white area. They said, but we don't know this happened because there was inflammation and these are the results of inflammation, or these increased and caused the damage. Another important potential mechanism for myocarditis is molecular mimicry. Yay, that is what I have been talking about for so long. So again, molecular mimicry is very common with viruses for um, heart inflammation. And what happens is, so let's say this is a cardiac tissue, and this tissue has this pattern on it, a protein pattern. And then here is spike protein, and spike protein just by chance also have that pattern. And now when you make an antibody against the spike protein, it may actually cross react with our own tissue as well. And this is called molecular mimicry. So check this out. They say another important potential mechanism for myocarditis is molecular mimicry between the spike protein of SARS-CoV-2 and the self antigen, that is the cardiac tissue. Antibodies against SARS-CoV-2 spike glycoprotein have been experimentally shown to cross-react with structurally similar human peptide protein sequences. So they say there is a possibility. We are seeing antibodies produced against spike protein reacting to human tissue. However, so they have howevers because there is no confirmed case. However, severe adverse events or autoimmune reactions have been very rare. If this was a molecular mimicry, their point is it would have caused a very severe myocarditis, and they are not seeing that with the vaccines. Although COVID-19 vaccination does not appear to provoke de novo immune mediated adverse events, it is possible that it may trigger pre-existing dysregulated pathway. So, in certain individuals with predisposition resulting in a polyclonal B cell expansion. So they're saying that in some individuals there may be immune dysregulation. Fine, but still there is no proof. Then, so if you see here, another mechanism, and that is ADE, antibody dependent enhancement. And the reason that they're thinking about that is the following. They talk about both. Let's say somebody is infected here. Because ADE, if it is occurring, will occur after the infection or the vaccine. It's not correct to say it would only happen because of vaccine, or it will only happen because of infection, or it would happen because of a vaccine but not happen because of infection. It would happen if the exposure is a problem, then infection or vaccine first dose will then predispose a person for ADE with the second exposure. So they're saying, let's say somebody was infected and recovered, or somebody had dose 1, and now at the time of dose 2, or let's say another exposure to infection, this is the concern that ADE will occur here, right? And so I think they've written the same thing as I have been discussing for many, many months now. In the non-human, they were able to see ADE. Fortunately, in humans, the signs and the proofs of ADE are not seen. So you would see that they say this. However, no evidence. So if this paragraph, if you look here, earlier animal studies of vaccine and Middle East respiratory syndrome coronavirus has raised concern of enhanced disease. So that is the context. However, no evidence of either cellular immune enhancement or antibody dependent enhancement of immunity was observed in non-human primate studies after SARS-CoV-2 virus challenges, either after vaccination or previous infection. And this is an important thing. People have injected this myth, rumor in the system that somehow vaccine will predispose a person towards ADE and infection will not. If ADE is going to occur, that is antibody dependent enhancement, then a person would develop that after any reason that made the antibodies. That can be infection or that can be a vaccine. Fortunate for us, it doesn't happen with this virus. So antibody dependent enhancement of immunity was observed in non-human primate studies after SARS-CoV-2 virus challenge, either after vaccination. So actually no evidence. So they didn't find it. These findings led a National Institute of Health ACTIV study panel to conclude that the risk of immune enhancement after COVID-19 immunization was low, but required ongoing pharmacovigilance and monitoring. None of the agencies would say we can tell you 100% with 100% assurance that this would not happen. They would always say, yeah, we don't think it is going to happen, but we'll keep observing, and you should keep observing too. To date, neither COVID-19 disease nor the new COVID-19 vaccine. So see, they're talking medical. So this, again, I'll say it, this is a myth that somehow vaccine would do it and the infection. Anything that would cause the first exposure and antibody production. If ADE is going to happen, then the ADE is going to happen with the next exposure. So that is why they keep putting them together. It almost looks like Mubin wrote it. To date, neither COVID-19 disease nor the new COVID-19 vaccine have shown evidence of causing antibody-dependent enhancement of immunity or other forms of immune enhancements with re-exposure. So see, they didn't say with second dose or with infection. They said re-exposure. Second dose is a re-exposure. Actual infection happening again is also a re-exposure. So people infected with SARS-CoV-2 have not been reported to develop antibody-dependent enhancement of immunity on a repeat exposure and so on. So I think we made this point. Then what other possibilities? Delayed hypersensitivity reaction, allergic reaction. There is an immediate allergic reaction and then there is a delayed allergic reaction. A delayed allergic reaction could occur a few days later. So they said maybe we can think of this, maybe myocarditis is actually a delayed immune response 2-3 days later. And they said, again, there is a however to that, and that is there have been observations of delayed reaction for which manifests as skin issues, but they have not seen that with the heart. So they talked about that as well. Then they go to the next one. I really love this article. This one, next mechanism now. Maybe it is the thrombosis and thrombocytopenic thrombotic purpura, thrombotic thrombocytopenic purpura, clotting. So this is a very, very important point. Even for me, this was an interesting observation, and that was, although very rare, thrombotic complications have been reported after mRNA COVID vaccines. These patients, the one of the myocarditis did not have thrombocytopenia or antiplatelet antibodies. And I'm kind of once again comfortable. Remember, I had been saying that the clotting is occurring because of the platelet factor 4 antibodies. Look, they're talking about the same antibodies. And at that time, there was so much that it is really not the platelet, it is the endothelial damage, and it is, anyways. Um, Antiplatelet antibodies were not observed in these patients. So that means they had myocarditis, but they didn't have clotting. So clotting causing myocarditis is ruled out. And then they talk about various markers, blood markers as well to prove their point. So we are still stuck. There is no clear picture for who will have it or what is really the cause of it. We know that there is inflammation of the heart. What is causing that is still not known. And again, I think for completion's sake, although I don't believe in it, but many people have been talking about it and many people have made it a mainstream uh, concept that this may be because of vaccine entering blood vessels. So I think they should have put that over here as well to say aspirate or don't aspirate, and the possibility of the vaccine in the blood vessels, and could that have caused it. So they don't have that here. An important possible explanation. So now, why male predominance? An important possible explanation related to sex hormone differences. Testosterone is thought to play a role by a combined mechanism of inhibition of anti-inflammatory cells. Anti-inflammatory cells in our immune system's behavior. Remember, when the war starts, so let's say this is the innate immune system. This is a macrophage or a dendritic cell or a NK or neutrophils, some cell, but let's call it macrophage or dendritic because they are more prone to do what I'm going to show here. So let's say they pick up the antigen, vaccine related or infection, and now they activate the naive T cell, and then naive T cell goes the path of T helper 2 or T helper 1, correct? So the testosterone, what happens is they're saying when this activity starts, so we know that the naive T cell would either go the T helper 2 pathway or go T helper 1 pathway. T helper 2 pathway would then go B cell to plasma cell conversion and antibody production, and T helper 1 pathway would go the cytotoxic T cell production or activation. In the same time, when this mechanism is being triggered, at the same time, so either going this way or this way, at the same time, T regulatory cells, T reg cell, normally T helper 17 regulatory cell subset is also activated. Their job, and some other anti-inflammatory or balancers, just that's my term, their job is to slowly in a few days tell the active cells to say, calm down, stop doing this, we are done. So their T regulatory cells function is to then finish or turn off the inflammation. And so what they're saying is testosterone is thought to play a role by combined mechanism of inhibiting anti-inflammatory cell. So testosterone inhibits these cells. That means in men, ideally, in the presence of testosterone, inflammation would continue for longer than women. And maybe in younger ages, testosterone levels are more than in higher ages, and that may be a reason. On the other hand, in women, the estrogen is responsible to do the opposite of this, and estrogen promotes the anti-inflammatory behavior. So women have an interesting outcome now. On one end, they have a lot of autoimmune diseases, so they're prone to immune system dysregulations or responses which are a little more aggressive compared to men. But at the same time, they have a better anti-inflammatory system compared to men. So they both have their own hormonal hormone dependent mechanism difference. Now, assessing the risk, this is interesting as well. So what they're saying is here, this side is vaccine induced or vaccine associated myocarditis. This side is COVID associated myocarditis. So for example, I'm just going to read a couple of things. 12 to 17 years of age, female, vaccine associated, 8 to 10 myocarditis cases. Males, 56 to 69 myocarditis cases. This is per million, I believe, for every million second dose. Here, for the COVID infection, females, this age group, 12 to 17, 8,500 COVID-19 cases, 183 hospitalization, 38 ICU, 1 death. Males, 8,500 COVID-19 cases, 183 hospitalizations, 38 ICU admissions, 1 death. That almost seems like copy paste. Maybe it is exactly the same number. It doesn't make me feel comfortable. It's 100% the same. Then 18 to 24, 4 to 5 on the vaccine side, females. And why do they not have death here? Because death did not occur. Males, 45 to 56. And on this side, COVID, 18 to 24, just see here 13 deaths in females and 3 deaths in males. So their point is that vaccine, although it may cause myocarditis, it is, number one, not going to lead to death, and number two, incidence is low compared to COVID-19. Okay, so then management, the last part of the discussion, and I cannot imagine it's already an hour. Thank you very much for sticking out with me. So management of strategies. What happens? How do we manage these patients? Although rare, clinicians should be aware of the myocarditis and pericarditis risk. So do you remember that in last year, I continue to talk about we should be ready. We should have a protocol. Protocol should be announced. We should know what to do when this would happen. And every time I'll talk about the vaccine side effects, especially clotting or myocarditis, people would start just hitting me. And my point was, we need to be ready. So doctors and nurses and NPs and PAs, and we should know. So here we are. That is why I really love this article. They have completed the picture here. They've not said, all right, vaccines would do this and COVID would do this. Thank you very much. We gave you some data to go and discuss with others and play politics with. Here they said, this is doctoring, that, hey, this can happen after the vaccine. Here is the epidemiology. Here's the possible pathology. Here are the clinical, the labs. And here is how to manage them. So for suspected cases, so let me actually go back here. Clinicians should be aware of the myocarditis and pericarditis risk. Number one, we should be aware this can happen, which should be considered in individuals presenting with chest pain. Number two, if patient comes in after vaccine 2-3 days later, says, I have chest pain, suspect myocarditis. Within a week after vaccination, especially in the younger population, for initial evaluation, what do we do? EKG, cardiac troponin level should be obtained. Inflammatory marker as, for example, C-reactive protein and erythrocyte sedimentation rate. Erythrocyte sedimentation rate is how the red blood cells are sedimenting in the blood. And what that means is, if there is inflammatory system, there are inflammatory proteins, they are going to, like little dust, they're going to settle on RBCs and make them heavy. And so RBCs would start settling down more fast. So erythrocyte sedimentation rate increases when somebody has inflammation. Mostly chronic inflammations also have increased ESR. So what are the things to do? EKG, troponin levels, ESR, and C-reactive protein. For suspected cases, now if you suspect that the patient has it, cardiology consultation and evaluation with echo and cardiac MRI should be considered. So if you suspect that this person does have this myocarditis or pericarditis, then number one, connect with a cardiologist, and number two, go further with further testing, and that would be echo and MRI. Echo can actually show reduced ejection and reduced ejection fraction because the heart is swollen, the tissue is swollen. So there is less space inside the cavity of the heart because the heart is swollen. So there is less volume of blood in it, there is less volume of blood getting out of it, and so on. So the echo would show those volume abnormalities, even movement abnormalities, because part of the heart is swollen and aching and is tender. Similarly, MRI would show the edema or fluid accumulations in the congested areas. An evaluation for acute COVID-19 infection should also be done. Then evaluate based on age and clinical presentation and so on. EKG changes should be observed. So that means EKG has to be done again and again to make sure that changes are not moving towards more cardiac damage. Imaging abnormalities are seen, arrhythmias are seen, hemodynamic instability is seen. So, and if necessary, patient may have to be hospitalized. Now, in published case reports, in addition to supportive care will be, for example, if the patient needs fluids or if they need, they cannot breathe correctly, so they need oxygen or they need painkillers. So in addition to the supportive treatment, non-steroidal anti-inflammatory drugs, steroids, and colchicine were used for management of some of the patients with myocarditis after COVID-19 vaccination. So that was one package done by some doctors. A few patients were treated with intravenous immunoglobulins and aspirin, and some were initiated on beta blockers and ACE inhibitors. ACE inhibitors help the heart because of left ventricular systolic dysfunction. So now, what are the solutions? Supportive care, then steroids plus non-steroidal anti-inflammatories, or IVIGs, aspirin, colchicine, and then beta blockers and ACE inhibitors. Among patients with rapid resolution of symptoms with preserved cardiac function would mean heart is not swollen this much that enough volume cannot enter and enough volume cannot exit. So if the volume is preserved, that means heart is mostly functioning normally. Normal biomarkers or resolving cardiac biomarkers marker abnormality, then therapy can be delayed. So if you're seeing that biomarkers are improving, cardiac condition is better, echo shows proper volume changes, normal volume changes or volumes, then don't start any therapy. In patients with persistent mild symptoms without hemodynamic instability, that is, once again, no issues with the blood pressures, blood volumes, echo seems normal, but patient still has continuous symptoms. No arrhythmia, no significant left ventricular dysfunction or heart failure. So in such patients, so there is a condition. What is a condition? Symptoms are persistent, but volumes are fine, heart is fine. Then colchicine, non-steroidal anti-inflammatory drugs, and steroids may be considered. In patients now, please remember I saw the disclaimer, American Heart Association said this is not necessarily our point of view, this is the authors. So in patients so similarly, it is not my point of view, this is authors. I'm presenting a paper. In patients with left ventricular dysfunction, heart failure, new onset arrhythmia, so either their left ventricle is not working correctly, or they are in a heart failure, or they have a new arrhythmia. They didn't have the arrhythmia before, but they just developed arrhythmia. Or hemodynamic instability. Their blood volumes are not correct. Their ejection from the heart is not correct. Heart is not filling correctly. So there is a problem somewhere. That means the heart is swollen enough and is tender enough that it is not functioning correctly. So what do you do in this case? Intravenous steroids and intravenous immunoglobulins along with other cardiac or circulatory supportive measures may be considered. In patients with left ventricular systolic dysfunction, that means during the systole is not working correctly, guideline directed therapy including beta blocker and angiotensin converting enzyme inhibitors should be initiated. And they're saying guideline directed. That means every hospital may have a different guideline, but most of them would come under AHA's guidelines. Management should include a cardiologist for initial assessment, evaluation, treatment, and follow-up, and an infection disease specialist for guidance on subsequent immunization strategies. So this is the discussion. Thank you so much for hanging out with me for 1 hour. It is exactly an hour and 1 minute. So please like, subscribe, and share. I know it is too much time, so I'm gonna let you go. Please like, subscribe, and share. If you would like to support this work, there are 3 links in the description. You can buy me a coffee, or you can use PayPal, or you can be a patron. Thank you very much. And as I had said before, we'll continue with our chit chats every other day. You tell me, I'm going to read the responses here. Tell me, do you want the chit chat today as well? I can come back, but if we can stick to the schedule of every other day, that would be amazing. You tell me. So the question to you, and while I would hang up, I can still see your chat.